Welcome back to BYOS Academia. I'm Dr. Mahziba Rahman Chowdhury. Today, I will be talking about a very important topic, that is biometry and IOL power calculation. So let's go back a little in history. This all started with Sir Harold Ridley. What did he see? He saw that during the World War II, the soldiers who were getting injured by the airplane acrylic canopy material, he saw that this material did not cause any inflammation reaction in the patient's eye. So that is where he got the idea that what if I use this material to make an intraocular lens? With this in mind, he started working, and the first intraocular lens was implanted in the year of 1949. But unfortunately, this patient had a post-op refractive error of minus 21 diopter. Now, in the year of 2025, this kind of mistakes we cannot have, because cataract surgery is not only a vision restoring surgery, this has now become a refractive surgery. That is why the importance of biometry is of so much importance right now. So, what is biometry? It is the art of applying mathematics to biology. What is done here? Measuring the anatomical dimensions of the eye, such as the corneal curvature, axial length, and then using this data to determine the appropriate intraocular lens power, which will be implanted during the cataract surgery. There are some ocular dimensions which we were saying that we need to get the IOL power. So we need the keratometry of the eye, we need the axial length. This is the minimum. These two are required by all the formulas. But we will be talking about them, the newer formula. They require some more data. They require the white to white, they require the AC depth of the eye, the lens thickness, the central corneal thickness, and lastly, very important, ELP, that is the effective lens position. So these are all the data which are required by the new formula. So why am I talking about this? Because most of the inaccuracy in biometry was seen that effective lens position, ELP, is responsible for 35% of the inaccuracy. So right now, we cannot only talk about the axial length and keratometry, we also have to think about all these variables. Before we go into biometry, we need to think about the ocular surface, because as we can see from the picture, look at the cornea. If we do a biometry in this cornea, there will be an error. So we need to treat this patient, then go for the biometry. This we always have to keep in mind. Now for the biometry, there are different methods. There's the ultrasound biometry, there is the optical biometry. We will be covering all this. So let's first focus on the ultrasound A-scan biometry. It can be done by the contact method. It can also be done by the immersion method. So for the ultrasound A-scan biometry, as we were saying, the minimum two requirements, keratometry, axial length. Let's first talk about these. What is the keratometry? Keratometry is the measurement of the radius of curvature of the anterior surface of the cornea. This can be done with many machines, such as we can do it with the manual keratometry, we can do it with the autokeratometer, we can do it with the IOL Master itself, or our tomography machine also gives this reading. But we need to follow some guidelines. The machine should be calibrated. We should not use any eye drops before keratometry, as it might alter the reading. Contact lens wearer, for soft contact lens, minimum 48 hours prior to biometry, it should be removed, but it's better if we can do it 7 days removal. And we know that the average K reading is around 43 to 44. So if we get a K reading too high, more than 47, too low, less than 40, what do? We repeat the K readings. And it's always, we must take reading from both the eyes. Why are we talking about these guidelines? Because one diopter of error in keratometry will lead to a postoperative refractive error of 1 diopter. Let's have a look at the sources of error. Very normal things, like look at the way the patient is sitting. His forehead is not resting. And over here, the lateral canthus is not aligned with the marker. These small things will help in proper reading. Another thing, as we were talking about, that the cornea. What happens is when we take the biometry reading, what do we say? Keep on looking, apni takiye thaken. But what happens when we do this? Let's see that the tear film meniscus, it's drying up. So when the patient stares for so long, this can also result in an inaccurate reading. So when we are taking the reading, we can just say, okay, now close your eyes, open again. Now we are going to take the reading again. This way we will get a good scan. So biometry, what did we do? We talked about the keratometry, and the next part is the axial length. Axial length for ultrasound A-scan biometry, we get it from the machine itself. So for contact A-scan biometry, what do we do? How do we do it? It's usually done in seated position. We give a target to the patient, topical anesthesia is applied, then we tell the patient to look at the target with the other eye. Then what do? With the probe, we just touch the central cornea. There cannot be any indentation. We align the probe, then we look at the spikes in the machine. So these spikes will tell us if the scan is good. So let's have a closer look at the 5 spikes. From A-scan contact biometry, these 5 spikes should be present. The first spike is from the probe tip and the cornea. Second is from the anterior lens capsule. The third spike from the posterior lens capsule. Fourth from the retina, and fifth from the sclera. So all these 5 spikes has to be present, and they have to be of equal height. This will tell us that we got a good scan. And we should remember that usually the difference between axial length of the 2 eyes should not be more than 0.3 millimeter. There are exceptions, like if the patient has anisometropia or scleral buckling in one eye, then we what do is it's okay to have a difference, but usually the difference should not be more than 0.3 mm. And next, very important, 1 millimeter error in axial length can result in a large amount of error in the post-op refraction. It can lead to a 3 diopter error. So we have to be very careful as not to make any mistakes. Let's have the look at the sources of error. As we were saying, suppose this is the biometry scan from the same patient. Actually, the axial length is 24.6, AC depth is 3.2, and the actual IOL power of the patient is 22. But what happened? We indented the cornea, axial length went down for 24.6 to 24.18. AC depth, it also decreased from 3.20 to 2.63. And let's look at the IOL power. It has increased from 22 to 23. So we'll be giving a wrong IOL to the patient if we had gone with the second reading. Another small mistakes is how we hold the probe. As I was saying, that 5 spikes should be present. Over here, the scleral spike is absent. Why? Because the probe is taking data from the optic nerve. So misalignment of the optic nerve should be avoided by, how can we do it? Holding the probe parallelly, and second, seeing that all the 5 spikes are present or not. Now, after contact, we will talk about immersion A-scan ultrasound biometry. The immersion A-scan what happens? The probe does not touch the cornea, so the error from indentation is completely removed. And of course, if we compare the two, the immersion technique has better repeatability. So this is the better option. Over here, the patient lies in supine position, same topical anesthesia is applied, then the scleral shell is applied on the eye. The patient fixates with the other eye, and what we see in the machine are again the spikes, but previously there were 5 spikes. Now there will be 6 spikes present, one from the probe, second from the cornea, then anterior posterior lens, retina, and sclera. So all these 6 spikes should be present and of equal height. Some guidelines for A scan is number one, always we should ensure machine calibration. The gain is usually initially set at a low level. We should choose the proper velocity, and we shouldn't settle with one reading. As we can see here that I have taken 10 readings of the axial length. So we can see if there's any discrepancy. And also the spikes, we should see the spikes. We shouldn't push too hard in case of contact A scan method. And always readings from both eyes should be taken. And in extremely long, short eyes, it's always better to repeat to see if the data is correct. Now, from ultrasound, we will move to the optical biometry. These are the newer machines. So optical biometry, there are many in the market. So I'll be talking about a few. Those are easily available. So the first that came into the market was the partial coherence interferometry technology, which was in the IOL Master 500, which was brought out by Zeiss. Then another one we talk about is the Lenster, which is by Hackstraight, and it follows the principle of optical low coherence reflectometry. The new one in the market is the IOL Master 700 by Zeiss. What is follows is the swept source OCT technology. So the difference over here that it can measure the total keratometry. All the keratometry we were talking about, it only measured the anterior corneal surface keratometry, but this swept source OCT can measure the posterior corneal surface as well. So this gives a total keratometry reading. And the Barrett formula, which we'll be talking about next, is incorporated here. So optical biometry, it's non-invasive, automated. So you can see that the patient compliance is much more, the patient is much comfortable with it. And I'm not going to mention any studies because all the studies are showing that this is definitely more accurate. So if in our practice, if we can afford it, it's always good to acquire an optical biometry. If we see the difference, accuracy is good in case of the ultrasound method if the technician is skilled, but non-contact, the accuracy is always good. Patient compliance is much better with non-compliance. The only limitation with non-contact biometry in case of dense cataract, like a grade 4 wide, sometimes the reading does not come. That is why the older machine, that is the ultrasound machine, we will also keep this and take readings from both the machine always. Now, let's have a look at the biometry scan. What are the things we see? Number one, for all biometry, the name of the patient, the eye of the patient, we have to match with the file. Once that is done, the values we see is number one, we were talking about the 5 spikes are present. Then we see the AC depth, because if it's too shallow, we need to plan our surgery accordingly. If it's too deep, we need to again keep in mind that our phaco growth has to go in much deeper. We see the axial length, is it between 22 to 24, which is the average axial length, or if there is any difference that is less than, it's a short eye, long eye, then we need to repeat the biometry. Next, we see the K1 and K2 values. This is the value which tells us if the patient will need a toric lens or not. If the K1 and K2 value, the difference between them is less than 1, usually we can avoid a toric IOL, but if it's more than 1, the patient, should advise a toric IOL. Next comes IOL formula. Over here, the SRKT formula has been used. I'll be talking about formula later. And And next is the which A constant. The A constant is for one IOL, the A constant is given by the manufacturer for every IOL. It differs from one IOL to another. So why am I talking about the A constant? Because I'll just sharing this slide that when I'm using an ultrasound biometry, the A constant of the same IOL, over here I'm just showing you an example IQ, it's 118.7. This is an optical biometry. Over here, what I'm seeing, again, same lens IQ, but the A constant over here was 118.7 in ultrasound, but for optical, it has become 119. This is given in the box. I don't need to go and find it. So, but I have to put the proper A constant in the machine to get a proper IOL power. And after that, we will be seeing that this is the same, the reading from an optical biometry. The readings are similar, axial length, ACD, lens thickness. Some are different. That is, it also gives the white to white. And also, as I was saying, that newer formulas, that the Barrett formula are incorporated into the new optical biometers. So as I was saying that we'll be talking about formulas now. So there are many formulas. The first, second generations, these are obsolete. The third and fourth generation, we are usually work with these. So another way of classification is by the method it used to determine the IOL power. The historical, the regression formula, these are obsolete. Mostly now what we use is the Virgin's formula, that is the Holaday 1, SRKT, Hoffer Q. These are available in mostly in our ultrasound machines. Then some Virgin's formula use 3 variables like the Haigis. Some use 5 variables like the Barrett Universal 2. Then there is the Holaday 2, which use 7 data, 7 variables. The artificial intelligence based formula like Hill, RBF, Kane also gives very good reading. And ray tracing is the new one, which is like the phaco optics, also gets good result. So many formulas. Again, confusion, what to use, what not to use. The good thing is that in case of normal axial length eyes, Holaday 1, Hoffer Q, SRKT, these all gives good results. But the question comes when the eye is short or long. What to do then? There are so many formulas, but to make life easy, I'll be just talking about the Barrett Universal Formula. I do not have any financial interest here. So it has shown that accuracy of intraocular lens calculation formula, the Barrett Universal 2 gives the lowest prediction error when compared to the Haigis, Hoffer Q, Holaday 1. So this formula we can use. Why am I talking about this formula? I'll just give an example. In normal axial length, all formula gives good result. But in case of short and long eyes, here we can see that the patient was high myope. The axial length was 30. Here, when I have used the SRKT formula, I got IOL power of -9. When same patient, I'm just changing the formula to the Barrett Universal formula, the IOL power suggested instead of -9, it's -5. So we have to be careful in case of extremes of axial length. This is where mistakes happen. So we all know it has been given in studies that Barrett gives good result in extreme axial length. So I'll be following the Barrett Universal 2 and implanting the -5 in the eye of the patient. Now, why am I talking about the Barrett? Because this is available free of cost. I don't have an IOL master, so I'm worried, where do I get this formula? No need to worry. Just go to the APA CRS website, and these formulas, that is the Barrett True-K formula, which is used for post laser vision, post LASIK patient. We can just do it over here. If I want to do a toric calculator, we'll use the Barrett toric calculator, Barrett Universal 2 formula for all those non-toric patients. RX formula is for if we want to do an lens exchange, if we want to do an piggy bank, we use this formula. And even for keratoconus, the 2K toric formula can be used. So all our worries can be solved by the Parrot formula. I'll just giving how do we just we put in APACRS, we go there, we see the formula, we check in the formula, and that's how easy it is. Then we put in all the data that we got from our biometry, we put in all the data, and we get the desired IOL power. So this is how easy it is. We can all start using it. Now I'm almost at the end. So at the end, I just want to say that we just need to be a little more careful. Follow some small tips like no eye drops should be given before keratometry. We should select the right A constant, the right IL formula. We should obtain data from both the eyes. And of course, if possible, move to an optical biometry, and always better to compare data from two machines so that we can avoid any mistakes. This way we can give the target vision that we have promised to the patient. That is all for today. I hope I could help in all of you to understand biometry a little bit better. Thank you.